our second sessions in orthopedic. So Dr. Abilash Kumar, who just joined us last year as a medical lecturer. So he's joining the orthopedic oncology unit, and also he's doing a trauma surgery at the moment. So he's going to talk about limb salvage surgery in orthopedic oncology, which is very common nowadays, because primary amputation, although it's still being done, is getting less and less common compared to limb salvage surgery. So without further ado, I'm just going to invite Dr. Abilash to start his talk for this morning.
Okay, my name is Abilash. I'm currently a first-year fellow in the musculoskeletal oncology unit under the tutelage of Professor Vivek and Professor Faissal. Today morning, I'll be talking about limb salvage surgery in orthopedic oncology. So this topic will encompass, one, what is the definition of limb salvage surgery, the bony defects we usually deal with in our practice, and how do we overcome these defects, the types and options of reconstruction, which is mostly these days, we talk about endoprosthesis and also biological reconstruction. So let's start off with the definition. Now, limb salvage surgery can be defined as a form of surgery where we go in and remove a malignant part of the bone containing the tumor, and we reconstruct the limb with an acceptable oncologic, functional, and a cosmetic result. So the type of defects we usually see in our practice can be divided into a partial or a full segment. Now, partial defects is usually a contained defect which we see in benign tumors or a confined tumor. On the diagrams to your left, you can see that it can either be a contained or a hemicortical defect. Whereas when you talk about a full segment defect, it's usually involving a bigger part of the bone. So in this kind of cases, we need to perform an intercalary resection, which can be either joint involving or joint sparing. So the types of intercalary resections here, we can see that there are, this one on the first diagram, A is an epidiaphyseal resection. B, we got a metadiaphyseal resection here, and in diagram C is an intercalary diaphyseal resection. Okay, so the options of reconstruction can be divided into biological and non-biological reconstruction. When we talk about biological reconstruction, we're actually talking about the usage of autografts, allografts, and recycled autograft. But when we talk about non-biological reconstructions, we usually talk about endoprosthesis. Now, there is a part where we can combine the usage of biological and non-biological reconstruction. We combine an autograft or an aerograph with the use of a prosthesis. And in that instance, we name it as an alloprosthetic composite. Now, in cases where the tumor eats into or enroaches into the neurovascular bundle, most of the time, usually it's not salvageable, and that's when the patients end up with an amputation. Okay, so first things first, let's look at the types of endoprosthesis we use in our practice. So endoprosthesis now is the gold standard alongside with allograft. It has very good early functional outcome. However, in cases of pediatric reconstruction, sometimes we cannot fully address the issue of limb length discrepancy in children. Now, it has shown to have aseptic loosening up to 8.8% and an infection rate of 8.5%. Now, this is about 8 to 10 times higher in cases of primary prosthetic joint replacements. The 15-year implant survival rate of endoprosthesis has been reported at about 50 to 55%. Patients usually have a very short-term good satisfactory outcome based on the MSDS score of 84%, which is the Musculoskeletal Tumor Society scoring system. However, the long-term outcomes are not very satisfactory in terms of endoprosthetic usage. So the diagram on the left is an example of an X-ray of a patient post-endoprosthesis application. So you can see here that this patient had a distal femur osteosarcoma, which we performed a resection. And this is an example of an endoprosthesis which we use in our practice. The gold color component is actually the femoral part, and the blue color component is the tibial part. Now, these days, the components are very modular, so it's very easy to go in and interchange the parts if necessary. So this is the patient 3 years after having the reconstruction, and she seems to be performing very well. She's got no complaints. This was a recent video which we took in clinic. Okay. Next, here we've got a 37-year-old female. Now, she was diagnosed with a rare form of epithelioid angiosarcoma of the left scapula. On the first X-ray on the top left, you can see that there's a lytic lesion over the left scapula, also involving the glenoid, part of the proximal humerus, and the acromion. So we performed a wide resection for this patient, and the top right diagram, you can see here that this is a custom-made scapular endoprosthesis together with a reverse total shoulder implant, because we had to sacrifice a bulk of the muscles surrounding the shoulder. So this required the patient to have a reverse shoulder component as well, because it will help with her shoulder function. She is now 3 months post-operatively. She seems to be doing well, and she's currently under the oncology team follow-up for adjuvant radiotherapy. Here, we have a case of a pelvic chondrosarcoma. So in this case, we removed, we did an internal hemipelvectomy on the right side, as you can see, and we attached a high hip center to the patient's sacrum with a proximal femur endoprosthesis. And this is her walking in the ward. Now, this patient unfortunately had a bout of surgical site infection, but she's treated well now and she's back on her feet. So I'll just speed this up. She seems to be doing fine. She's happy. She's actually a dancer and she's looking forward to going back to dancing. Next, we are going to talk about a bit of biological reconstruction. So when we talk about biological reconstructions, we actually have an absolute and relative indication. Now, absolute indications for biological reconstruction involve a contained defect. Sometimes in tumors of the lower limb, especially involving the midfoot and hindfoot, there's no available implant. But in these days, nowadays, we can get a custom prosthesis, especially for the calcaneum and talus. And also for ligament reconstruction in the upper limb, especially around the wrist, which we don't have a good implant yet, so we can opt for usage of biological reconstruction. Now, the relative indications are in cases where sometimes we deal with recalcitrant infections in prosthetic joint infections, requiring multiple revisions, upper limb tumors, and also benign tumors with soft tissue defects. So this is an example of a contained defect. This is the part of the tibia where the patient probably had a NOF or a GCT, where we went in and curated part of the bone. And here we can use a femoral head allograft, put it through the bone mill, got part of the bone chips, and we use the bone grafts, this allograft as a void defect here in the tibia. Next option of a biological reconstruction is actually the usage of a fibula autograft. Now, this fibula autograft can be either vascularized or non-vascularized, usually depending on the size of the defect or what we want to achieve in the reconstruction. Vascularized fibula autografts are usually used in long segment defects about 8 cm and above. But the issues with this is that it requires microsurgery, so we might need the help of our colleagues from the hand and micro unit or the vascular surgeons. Now, it does come with its complications, infection post-chemotherapy, wound complications, they also come with donor site morbidity, and the rehabilitation is always slower because we need to always wait for the union at the graft site. And in some instances, we do end up with non-union. So this is an example of a usage of a vascularized fibula autograft where the patient actually had a distal radius GCT. So you can see here, this is where we had to perform a wide excision of the radius bone. And this is actually the usage of a reverse proximal fibula autograft, which we implanted into the wrist joint and fused it to the carpal bones. And this is the result after 3 years. She's got a good range of motion of the of a right wrist now. Next, we talk about allografts. Now, the advantages of allografts is it can support mechanical load. You can reattach the post soft tissues, and the size can usually be matched to the defect which we've already excised. Now, the disadvantages are disease transmission. You can get non-union and strength issues because these allografts are usually processed. So although they are mechanically strong, but it is not as strong as the patient's original bone. So here we have a case of osteofibrous dysplasia like adamantinoma in the tibia, where you can see after the first few surgeries which have done, the tumor actually came back. So in the middle picture here, you can see that this is the usage of a humerus allograft, and this is the excised tibia which we had to remove containing the tumor. So we matched the size of the humerus allograft which we're going to use, and we implanted it into the patient with the help of plates. Now, this is a technique developed in Italy called the Capana technique, where they usually merge the usage of autografts and allografts because this will help in the biology of healing. So the allografts gives us the mechanical strength that we need, and the autograph helps with the biology of healing. So you can see here that the allograft shell is actually opened in half, and we insert the vascularized fibula graft into the allograft, and you put it back into the patient's proximal tibia. So this will help. One, it's mechanically strong. Two, it helps with the biology of healing. So when we merge the usage of biologics and endoprosthesis, we come up with the alloprosthetic composite. Here you can see there's an example where there's a intra-articular resection of the distal femur at this level. So the part where the metadiaphyseal region was actually reconstructed with the help of an allograft. However, the articular surface here, we opted to use a prosthetic joint. Why? Because sometimes osteoarticular allografts, they tend to degenerate very fast. They're not as strong, and patient usually ends up with instability of the knee joint. So hence, this is another way to overcome those problems. Okay, recycling autographs. What does recycling autographs mean? Okay, recycling autographs mean that when you excise a tumor, we sterilize it and reinsert the same bone back into the patient. Now, to do this, we need to ensure that the part of bone that was excised has 100% tumor kill. So the aim of this is to make sure, one, you got 100% tumor kill. Two, you maintain some of the biology, the cellularity and the osteocytes and all that in the bone while achieving 100% tumor kill. So how do we do this? There are a few methods: pasteurization, extracorporeal irradiation, autoclaving, and liquid nitrogen. So recycling autografts has its advantages. One, you get a precise anatomical fit. There's no donor site morbidity. There's no risk of disease transmission. You avoid an immunological reaction. You avoid the complications of prosthesis, i.e. loosening, breakage, wear, cost. It's a much cheaper option. And there's a potential preservation of the biology. The disadvantages is always once you treat the bone with one of these methods, it becomes mechanically weak and brittle, and also there's always a risk of local recurrence. So this is a locally produced paper here in UM by Prof. Vivek, which is the best method for sterilization of the tumor for reimplantation. So we found that all these methods, autoclaving, boiling, and pasteurization, they all give 100% tumor kill. However, sterilization by pasteurization and irradiation to a lesser extent, they do not significantly alter the mechanical properties when compared with other untreated samples. Another study by Prof. Faissal and Prof. Vivek here, you can see which is the best method of sterilization of recycled autograft in limb salvage surgery. So here we found out that irradiation and pasteurization have better favorable outcomes in terms of bony union. Autoclaving has the worst because of the high temperatures involved. Pasteurization has the best overall outcome in terms of osteocyte preservation and microcellularity. I think this is my last slide. This is a liquid nitrogen way of recycling the autograft. Now, this method is usually now widely done in Taiwan, if I'm not wrong. So what you do is what we do is you can see in figure A where you excise as an intercalary metadiaphyseal intercalary resection of the distal part of the femur. You soak it at about minus 200 degrees for about 15 to 20 minutes. Now, what this liquid nitrogen does is it induces microthrombosis in the microcirculation, dehydrating out the tumor cells by forming ice crystals. So once that is done, we expect 100% tumor kill, and then we reimplant the bone back into the patient with the help of implants. It's a short and simple procedure. You preserve osteoinduction and osteoconduction properties of the bone. You get to preserve the matrix. You get a perfect fit, yeah, because it's the same thing which you're removing, you're putting it back in. There's sufficient mechanical strength, and you don't get a transmission of, there's no risk of disease transmission or immunological reaction. You don't need a bone bank, and you get easy attachments of the tendons and ligaments. With that, I would like to thank you.
Okay, thank you so much, Dr. Abilash, for the talk. Yeah, I think
Thank
it's
you.
quite interesting nowadays that we have a lot of options to reconstruct the limbs. In the olden days, where amputation is the primary surgery, limb salvage nowadays is gaining a lot of popularity, not because it's easy to do, but because of the options that we have nowadays. I think in terms of the technologies, they have advanced a lot. In fact, the endo processes, we have a lot of designs and what is it? The designs and also the technology has changed. The limitation now in Malaysia is actually the cost, where we do get the cheaper options, which is coming from India, that can cost around about 20,000 to 30,000. The more branded one, maybe from Germany and USA, they can cost around about 50 to 60,000. It can go up to 100,000. Depends on the length and also the design of the endoprosthesis and whether is it a custom made or is it a modular endoprosthesis. So the good thing now we have allograft, which is available in University Malaya because we have our own bone bank. It's cheaper, but again, the allograft, for example, if you are using like whole femur, it can cost around about 5,000 ringgit. So maybe plus minus the fixation, it will add up around about another 5,000. So it's still cheaper compared to endoprosthesis. Okay, so we don't have, I don't think there's any questions in the Q&A box. I hope the listeners benefits from our sessions this morning with regard to obesity in childhood management and also on limb salvage surgery. I don't have anything else to add. So I hope everyone enjoy the rest of the weeks.
Assalamualaikum. Can I just okay for
Yeah, Dr. Nur Shahada, yeah.
how about in children who are growing? Is there any way that the limb salvage can also be done?
Okay, good questions. Okay, maybe Dr. Abilash want to explain first or answer that questions before I follow up with the answer.
Okay. Thank you, Professor. Thank you, Dr. Norshada, for the question. In limb salvage surgery in children, now it is challenging because one, we've got to calculate how much growth is remaining in the child. So when we talk about, let's talk about lower limbs now. So they grow about 6 mm from the proximal femur, 9 mm from the distal femur, 3 mm from the proximal femur, 9 mm from the distal femur, 6 mm from the proximal tibia, and 5 mm from the distal tibia yearly. So most of the time when we talk about tumors in children, they usually occur around the knee. So given the age of the presentation and the timing of surgery, we need to calculate what is the remaining growth length when they hit maturity at the point of 16 years old for males and 14 years old for females. So there's a formula which we apply. So by doing that, we can then decide now, look, okay, so we probably need a modular prosthesis one in growing children, which we can lengthen the prosthesis yearly. So for the femurs, we usually lengthen about 1.5 cm yearly. For the tibia, we're looking at about a 1 cm lengthening yearly. So this modular prosthesis also has only a maximum amount of length which you can lengthen. So now these growing processes now are very modular. If it comes to a point where the child is young, we do the surgery, let's say at the age of 7, he may need another surgery by the time he's reaching adolescence because we need the modular component can only substitute so much. So yeah, there is a method to overcome this, but it's challenging, and we're talking about maybe additional surgeries.
Yeah, true. I think there are many options for the what we call like an expandable prosthesis. As I said, the choice of implant depends on the financial support that they can get. Because the expandable endoprosthesis can be either invasive, where you have to open up the site of the prosthesis to lengthen, and the other one which is non-invasive, they actually use like a scanner or like an MRI scan sort of things, where they can actually expand the prosthesis. But as Dr. Abilash mentioned, the challenges is to catch up with the growth of the patients in the pediatrics group until they reach the skeletal maturity. And the other issue is actually they may require revision surgery when they reach adolescence or adulthood. And then, of course, the limb length discrepancy is the issues. And when the bone grow also, because the diameter of the bone become wider, then the implant can become loosened. So that is also a challenge. Sometimes the patient doesn't feel comfortable when the implant become loosened. So I mean, we do consider sometimes the youngest patient that we have operated so far is around about 6 years old. But of course, when they have early surgery at a younger age, they always comes with an associated complications because they have multiple surgeries and exposures to risk of infections and also implant failure. That is the challenge, really. But of course, in cases where the tumor are big and then it's not salvageable, I think it's best sometimes to consider amputations in the pediatric groups because, as you know, in the pediatric groups, when they have amputations, they can adapt well with the prosthesis, and in fact, they do quite well with the prosthesis when they grow adults. As an adult, so I think that's also another option that we shouldn't forget because sometimes primary amputation may be more beneficial than a limb salvage surgery in certain situations.
Thank
Okay, I
you.
hope that answer the question, Dr. Nushadia. Yep.
Thank you for excellent talk, Dr. Abilash,
Yeah.
and thank you for a very comprehensive answer.
Yeah. Thank you. So just about not close. Okay, one more question I think before we close. We have about 5 minutes. Good morning. I would like to ask, is there any limitation in weight loading on endoprosthesis? Abilash?
No, I don't think there's because the minute you do an endoprosthesis, it's like a joint replacement surgery. But the implant should be stable enough or strong enough to bear the patient's weight. But when we do an endoprosthesis, but right, if the surgery goes well, there's no propagating fracture line or whatnot, the patient should be able to weight bear the next day.
Yeah. And there's no limitation, to be honest. Of course, if the patient is gaining weight throughout the way, then they become more obese. And then, of course, the risk of implant loosening and failure is very high because, in fact, endoprosthesis itself has a higher failure compared to the normal joint replacement because they are a larger implant. But in terms of limitation, I always say to the patients, once they are back to normal, try to be as active as possible. They can do cycling. They can go for a brisk walk. They can go for swimming. And keep themselves active as much as possible. Okay, I think that's wrap up the sessions for today. I think thank you so much everyone for listening. I hope everyone. There's another question. I think baru nak close. Okay. Thanks for highlighting that isn't the best. I hope. Yep. I agree. Yes, that's why we always have to don't forget about the primary amputation and prosthesis because some patients they do benefits from having a primary amputations and prosthesis. Yeah. I agree. Okay, thank you so much. So I hope everyone enjoyed the breakfast talk today and have a good weeks ahead. Thank you.
Yep.
Bye bye.
Thank you, everyone. Assalamualaikum.
Thank you.
Thank you.